My name is Steve Barnes. I'm Assistant Dean of Public Affairs at the Princeton University's Woodrow Wilson School. Thanks for joining us this morning for what I'm sure will be an interesting and insightful discussion about the next president's health care reform agenda. And fortunately, in the last 18 to 24 hours, nothing of interest has happened in Washington related to the economy that might impact the health care debate. So that's not a worry whatsoever for our panelists' remarks today. Before we begin, just as a bit of housekeeping, I ask that you please shut off your cell phones, Blackberries, iPods, Game Boys, whatever you may happen to have, so we can enjoy this discussion without disruption. And just as another bit of quick housekeeping, I just would like to mention here that today's discussion is sponsored by the Woodrow Wilson School as part of our ongoing Washington seminar series designed to encourage serious debate and analysis about some of the most pressing policy issues of the day. As I said, we're examining health care reform this morning, and we're fortunate to be joined today by some of the leading experts on this issue. In terms of the format today, just as soon as I wrap up with introductions, the format will be we'll hear from our panelists first, after which we'll open the floor to your questions. And since our time's limited, I'll get straight to the introductions. First, we'll hear from Joanne Silberner, who's health policy correspondent for National Public Radio. She covers medicine, healthcare reform, and changes in the healthcare marketplace. She's been with NPR since 1992, and prior to that, she spent 5 years covering consumer health and medical research for U.S. News and World Report. She's won awards for her work from the Society of Professional Journalists, the New York State Mental Health Association, the March of Dimes, Easter Seals, and the American Heart Association. We're glad to be joined by her this morning. Next up will be Professor Uwe Reinhardt. He's a professor of economics and public affairs at Princeton's Wilson School. He's recognized as one of the nation's leading authorities on healthcare economics, and he's been a member of the Institute of Medicine at the National Academy of Sciences since the 70s. Most recently, as some of you may know, he chaired New Jersey Governor John Corzine's commission to rationalize the state's healthcare resources. He's also president of the International Health Economics Association and is on the board of the National Institute of Healthcare Management. He is or was a member of numerous editorial boards, among them the Journal of Health Economics, the Milbank Memorial Quarterly, Health Affairs, the New England Journal of Medicine, and the Journal of the American Medical Association. In addition to Uwe's policy work and his ability to get published in the top academic journals, he's also got the uncanny ability to keep getting invited back on Oprah, which is a remarkable talent, I think you'll agree. And many of you, I'm sure, have seen him there discussing health policy with her and others. Truly remarkable, that. After Professor Reinhardt, we'll hear from Robert Moffit, director of the Heritage Foundation's Center for Health Policy Studies. He's a former senior official at the U.S. Department of Health and Human Services and the Office of Personnel Management during the Reagan administration. He specializes in Medicare reform, health insurance, and other health policy issues. Speaking of state health care initiatives, his team actually helped develop Massachusetts' Health Insurance Reform Initiative in 2005. Now, this plan created a system that allowed employees in small businesses to choose their health plan through a statewide health insurance exchange, it was called. Then Governor Mitt Romney signed this plan into law, as many of you know. Bob's research also involves him in continuing debates over how to reform Medicare, how to ensure access to prescription drugs, and how to improve access to private health care coverage. Batting cleanup will be John Rother, Executive Vice President of Policy and Strategy for AARP. He's responsible for the organization's federal and state public policies, for international initiatives, and for formulating AARP's overall strategic direction. As many of you know, he's an authority on Medicare, managed care, long-term care, Social Security, pensions, and the challenges facing the boomer generation. Prior to coming to the organization in the 80s, he served 8 years with the U.S. Senate as special counsel for labor and health to former Senator Jacob Javits, then as staff director and chief counsel for the Special Committee on Aging under its chairman, Senator John Hines. So, needless to say, we've got a great group, and we're fortunate to have them with us here this morning to tackle such an important issue in American public policy. So, again, since our time is limited, I'll turn the floor over immediately to Joanne. Thanks very much for joining us.
Thank you for that introduction, and I, like the rest of you, am very much looking forward to hearing the discussion among the panelists, so I'm going to get through this as quickly as possible. I want to give you the lay of the land right now, starting talking about polls and then what the two health plans are that are being discussed now. To the great consternation of healthcare reporters, in the past few elections, healthcare starts out really strong in terms of people's interest in what is going to be a voting issue for them, and then it drops. Sometimes we feel responsible, but when I look at the current poll, I realize it's other events have taken over. The Wall Street Journal had a poll out earlier this week that was taken last week. What's your top priority for the election? Number one was jobs and the economy at 25%. Financial crisis was second. This was last week at 18%. Energy and the cost of gas was 13%. Iraq, 12% of people rated that as their top priority. Healthcare was down at 10%. And by the way, there was another poll. The LA Times had a poll saying, who do you think could best take care of it? 54 of healthcare, that is, not the financial crisis. 54% said Obama, 25% said McCain, and the rest wouldn't say. Well, where are they? Before I tell you what their plans are, where are they right now, given all the chaos? At the AHIP meeting earlier this week, both said that their plans were remaining constant. On NBC earlier this week, Obama said that, let me see if I can get this right, he said his plan, when he said, he was asked, could you do anything right now on health care? And he said, probably not. I think we're going to have to phase it in. So at least he's saying that his plan may be going a little slower. So what are these plans? Well, let me start with Senator McCain. People say that it's the most radical of any of the major candidates this year because it basically scraps the current system of employers using pre-tax dollars to buy health insurance for their workers, and employers would lose that tax exclusion. But it does leave health insurance pretty much intact. It leaves the health insurance system there. So it doesn't go as far as other plans that have been discussed over the years, but looking at the polls, you can come to see that people may not be interested in that level of change. Basically, in working through the tax system, the employers lose their exclusion. Individuals would get $2,500 tax credit, families $5,000. I mean, basically, you can think of it as the government writing a check to the insurance companies, and then individuals or their employers would make up the rest. It's not going to be a small sum making up the rest, given that the average price for a family policy is $12,000. You're getting $5,000 from the government. You need to get $7,000 from somewhere else. People with health conditions, the big group of uninsured who can't get care, there is a guaranteed he would have a guaranteed access plan where states would set up plan. Actually, it's not clear to me whether it's states or the feds would, but there would be a plan where you could go and get it. It obviously has to be subsidized, and the level of that subsidy has changed over time. When it first came out, I'm pretty sure they were talking around $7 billion. I talked to Douglas Holtz-Aiken last year, and he said it's going to be more like about $20 billion a year to subsidize this guaranteed access plan where everyone could go. No one would have to get health insurance. That's a difference between his plan and Senator Obama's plans. You could buy insurance across state lines, which would basically weaken individual states' regulations, because if you've got a state that has strong regulations that may increase the cost of care a little bit, people are going to go into other states. And I'm going to leave the panelists, and I suspect this is going to be Professor Reinhardt, to follow this one out and say what it means to lose that, to lose some of the regulations that the states have. There are fewer regulations on insurers, and Senator Obama has been having a heyday with that one, the idea of dropping regulations on an industry that may not be so popular. There's a obvious parallel there to what's going on with the financial system. He, like everybody in this world, would like to somehow define and promote a best practices system so insurers are paying for what is good and useful and makes sense economically. People are already jockeying to be head of that organization, and it's be interesting to see. I suspect that with either candidate, we will get something like that at some level. There are lots of other things in his plans to bring down, costs, promotion of generic drugs, more prevention efforts. Health IT is in both plans. Big argument about whether that would lower costs. It would improve care, but the question of lowering costs is out there. Malpractice reform. HSAs, not surprisingly, drug reimportation. So there are a lot of details that don't translate into a headline, but it's basically insurance system stays intact, employers lose their exclusion, and a lot of it's done through the tax system. For Senator Obama, there is an employer mandate. It's basically a pay or play. Employers of a certain size would have to get insurance at some level or pay taxes. Kids would have to be covered one way or another, through their families or through the government. There would be a national health plan for the uninsured. This one sounds to me a lot like part of the supermarket idea that was in the Clinton health plan, where you would go to a place where there would be a government plan that you could buy, or private plans could also submit their insurance plans to be sold within that sort of supermarket that would be regulated and available for people who are having trouble getting insurance. There'd be an expansion of Medicaid and S-CHIP, subsidies for low income, small business tax credit, reinsurance for catastrophic costs to help out businesses that are, especially smaller businesses that are afraid to buy insurance because of the idea that one sick person could really wipe them out. There'd be savings from electronic medical records. There'd be income from dropping the tax cuts on the rich. There'd be disease management, which is one of the popular things in everything, and that's his plan. So the difference there is it's somewhat mandatory, although not universal. Individuals wouldn't have to, but if you're working, chances are you would have it. And what's going to happen to these plans with the financial things? Watch this space. It'll be interesting to see how much they have to revamp. What I want to leave the panelists with is a challenge that's cribbed from Bob Lashevsky's healthcare blog. And this was a week and a half ago. He said, or last week rather, he said, how could McCain, the challenge to McCain is how could he get a Democratic Congress, which he's likely to have, to go along with his plans to throw millions of people into an unregulated insurance market, a super unregulated insurance market, and for Obama, how can he get his plan through in the face of this crippling budget challenge? So.
I guess I'm up next. Well, I'm happy to be here. I should mention Joanne is one of my favorite Washington journalists. When she interviews you, she's clearly prepared. She read up on the issue and knows it. And the other thing, unlike Chris Matthews or Bill O'Reilly, she actually lets you finish a sentence, which those of us who are being interviewed really do appreciate. I would actually refuse to go on the Matthews show because the man is rude. The problem we now have with the current health system, it's great, as you know, it's the best in the world. We have heard that so often, it must be true. But it's pricey. There is a website, Milliman Medical Index, it's the old Milliman-Robertson, and they add together what families spend out of pocket and premium, the employer's contribution and the employers. They have a 10 million live database of privately insured Americans. And for an average, so that average is over healthy and sick and over ages, it's now $15,000 to buy health care for such a family in America. Now, of that, insurance usually covers some $12,000, and that's where that premium comes from. But there's a lot of out-of-pocket now already. And the compound growth rate here is in the neighborhood of has been 9%. So that's a lot of money when you look at the income distribution. This is 2005. Funny, we don't have them. Usually they're a couple of years lagged. But what I'm concerned about, I call them the blues. The Greens already get a fair amount of Medicaid, food stamps, housing subsidy. So Americans do fund money from here to here for them. But we never do anything for the blues, the cab drivers, the Home Depot workers, the people more than 20,000 and under 55, the hardworking stiff, usually two-earner families with two earners. We do nothing for them at all. And if you look, 15,000 a year, if you actually grow this out, say here you have a family, one works at Home Depot, the other one at Walmart, let their wage base grow by 3%, and let the total family health care grow at 9.5%, I have it here, and then see what happens to the relationship of wages. This is the wage base, which grows for this family from 50,000 to about 68,000. But here is health care. And as you can see, by 10 years from now, health care spending for this family be in the neighborhood of $36,000. That's probably what's going to happen. And half the wage base is chewed up by that. And so I think this is a storm we're sailing into. If you relate that, I have it here, the fraction of the wage base chewed up by health care alone, it's over half by then. For these sort of salt-of-the-earth Americans. Now, what this means, the employers initially will try to solve this problem just by shifting costs out of insurance into deductibles and co-insurance, but that still has to be financed by the wage base. It comes out of take-home pay. The next thing, though, is medium and small employers will just drop insurance. I think they just will. And you see when you follow the book of business of the private insurers, it's shrinking. And that's why they're pleading for Washington. In a way, they want universal coverage, but they want to be the purchasers of health care on behalf of government, like, say, Medicaid, managed care. There are, of course, people who are not insured who, in theory, could afford with their own money to buy insurance, particularly if they took a high-deductible product, but you have to make it available. You would have to restructure the insurance market for individual insurance such that people could actually afford to buy it. Now, Senator McCain's idea of deregulating, essentially deregulating insurance, because if you can buy across state line, the cheap states will be those that do not mandate a guaranteed issue or community rating. But an economist will tell you community rating, when being insured is a voluntary decision, will always lead to the death spiral of insurance. We see that in New Jersey. So we have an issue here that's both technical and moral. The take-home point is we now face an issue in America as voters where we have to decide either those of us in the upper part of the income distribution step up to the cashier's window and subsidize the blues, which we've never done before, or we ration them by income class. Say, if you're poor, tough. You die earlier, your kid won't get health care, and so on. And there was just a new paper out, Jack Hadley and John Holohan, and there was a third author. And they looked at what do fully insured people spend per year and what do uninsured, and the uninsured is about 43%. So there's got to be rationing in that. We're rationing already, unless you say, this is actually the efficient amount, and these people all overconsume. But that's you and me. So I don't think I overconsume health care. I hate it, in fact, when the doctors cut me up. Now, what would universal coverage cost? Their numbers, again, very carefully, I think, put together. I don't know, Bob, whether you agree with them, but I think the Hadley numbers were quite well done. Where the total actual spending on the uninsured and people who are partially insured part of the year is $176 billion, and to cover them fully and give them what their insured brothers and sisters have would add another $122 billion a year in health spending on top of it, which presumably the feds would have to pick up, or the government, the states, because if these people had the money, they would spend it, right? But they don't. So that's 122 growing at what? 8-9% per year. That's what we're looking at as a budget hit. On a per capita basis, well, why would you want to know this? But they had it in there. They worked it up on a per capita basis per uninsured, another $1,500, so you get to $38.85. So that's what we are facing. Now, can we afford this as a nation? We used to be one of the richer nations in the world. Here, however, is if you go to, I think I have a later one, it looks, however, just like that, 2005. This is all taxes added up that we spend, state, local, sales, you name it, added up as a percent of GDP. We actually are a low-tax nation. We don't spend that much in taxes now. You could say that's good. But what I'm saying is you cannot really look up to God and say, we'd love to be our brothers and sisters' keeper, but God, you know we're an overtaxed nation. We can't do it. I don't think it'll sell to God, because he said, look at Sweden, right? Because God knows Sweden too. Hard to believe, but... And there are people, PhDs, Nobel laureates, who come out with statements saying that rescinding the Bush tax cut would be devastating to the world economy. And I asked him, I'm going to write to him and say, you know something? Letting Wall Street bankers loose in an unregulated market, that can bring the world to the brink of disaster. How do I know it? President Bush just said it 2 days ago, right? That's what Mondale should worry about, and not taxes have an effect on economic activity and could impact growth. But it's about like hitting an elephant with chopsticks on the leg. It'll twitch, but the economy is not going to react very much to tax changes. Here is OECD numbers, taxes as a percent of GDP on this axis, and the growth, real growth, GDP per capita growth in a decade, 95 to 2005, 1 decade's average annual compound growth. Now, for a fee, I'll run you an equation through it, and if you give me the slope you want, I'll get it for you. That's what economists do, right? But I just have you ordinary people, not corrupt, you look at it and tell me where there is this tax effect. The other one I looked at, I go to the President's own report, and I plot on this axis the percent of GDP going to private investment. Business investment is the red, housing is the blue, and the sum is private investment in the U.S. And you can see actually under President Reagan that thing slightly declined in spite of all the supply side stuff. And then it declined more under Bush, under Clinton, who raised taxes, along with Bush Sr., by the way, raised taxes, the percentage rose. And after the big tax cut, the percent of GDP in private investment actually fell, but housing rose, and we all know that's what the bankers did. They say, that's what really makes us competitive. Those Chinese will come over here, they see our huge houses, and they say, Jesus, how can we compete with these people? I guess that was the growth strategy here. Now, if you give this to any economist, they'll say, well, taxes are only one of 1,000 variables that'll affect growth. And they say, yeah, that's true. But then don't tell the Wall Street Journal that not extending the Bush tax cut will be a devastating event for the world. If this was devastating, this was a tax cut. So I think this is a whole truckload of bullshine. The idea that we cannot give health insurance because it'll arrest economic growth is something you could never sell me. You could sell me oceanfront property in Iowa before that. If you look, well, this is savings, government saving. The purple line is Social Security and Medicare trust funds. We actually, we always pay in more than we take out. The red line is truth. This is the government's operating budget. What they actually do, they lie to you systematically by offsetting from the federal deficit the Social Security surplus, and then the deficit looks smaller. And most journalists fall for this. If I were a journalist, I'd say, enough of this. I'll always give both numbers, because the red is what the deficit is. This is a lie, and that's the one we publish, and that's the one politicians use. But that is accepted and expected. But journalists should be on the red line. And we're dissaving in a massive way now. So if you look at private household saving, that's pretty much zero. Americans, on average, don't save at all. So therefore, we actually have to finance most of that abroad. Now, there's a nice paper. If you Google Tax Policy Institute, would you call them reputable? Yeah. Yeah, I think so. And they do very, very, Eugene Sturley is one of the leading lights there. They estimate that Obama's health plan would add $1.6 trillion to the additional federal spending to over the next 10 years, and McCain's $1.3 trillion. They also have some numbers on how many people that covers, but maybe Joanne can get into that, or Bob. I have the numbers in my head, but those are soft estimates, of course. And then, of course, there would be additional spending. Their estimate is that the tax cuts of Obama and McCain are, over the 10 years, $3 trillion, because Obama will cut taxes for all kinds of people, except for the rich. He'll raise it. And McCain wants to extend the tax cut, so he will cut taxes by 4.1. If you look at this is not from stump speeches. Those numbers are much worse. This is from these advisors, Doug Holtz-Eakin and people like that, tell the Tax Policy Institute, Obama would increase the federal deficit by 5.8 trillion and McCain 7.3 trillion. So that's on top of everything that we have. And it was Jeff Lemieux, I don't know where he now is, but he used to be a very fine analyst at the CBO. And he once had this quote that made me sit up. He says, if this keeps going on, the biggest entitlement in the federal budget is not Medicare, but interest on the debt. That's an entitlement. Whoever holds a bond is entitled to get that interest. They happen to be in Dubai and China, but still, they're entitled. They stand ahead of our kids now. And on top of that, we now have this bailout for the Wall Street bankers. It'll cost $1 trillion. Ken Rogoff estimates the bailout will cost $1 trillion, and we've already done, what, 300. So, and all of that has to be borrowed. So do we have the money to be our brothers and sisters' keeper? And the answer is no. We have to worry about Goldman Sachs. That's where we are. Think of that. I mean, it's just, it is hard to contain your rage over the fact that we're taking federal money to bail out these people. I think they should, as a condition getting any money, be fired. Just fired. And number two, instead of buying their junk, we should say, we'll give you money and we'll take 30% of the equity. We'll own your companies. And then we'll sell them like Volkswagen was sold to the people after in post-war Germany. So if what we Americans spend on consumption, on private investment, including houses, and what governments spend is 106% of the GDP. Imagine a family spending routinely 106% of its income. The country is run this way. And this was $800 billion. So if you look, this is the annual borrowing from abroad. I don't know where you guys think that $1 trillion that we now need to bail out Wall Street has all to be raised from abroad, because we don't save. There's no money for us. So Mao Zedong must be laughing, saying, you just think of that. Here are the great capitalists coming with a tin cup, begging us to bail them out. And that's where we ended up. But what I'm telling you is, I just don't see where the money is when Obama says that. We have to phase it in. Basically, it says, don't trouble me with this. I got Goldman Sachs to worry about. That's where we are. So I'm pessimistic on actual health reform for both, whoever would win. Do you have slides?
No.
Oh, geez. How can you speak without slides?
I manage very well. Well, Steve Barnes, thank you very much for inviting me, and members of the Woodrow Wilson School. It's always an honor and a pleasure, and it's always entertaining to be on a panel with Professor Reinhardt. And, of course, it's always good to be with John Rother. John Rother and I have known each other for a long time, mostly on the opposite sides of just about every issue in Washington. John and I normally don't even agree on the direction of the rainfall. Steve asked me to talk about what I would say to the next president of the United States about health care reform. In terms of, what advice or counsel would I give either President McCain or President Obama? I expect that in some cases I would have a better hearing, one White House than another. But I would say to the next president that to remember that when we're dealing with this issue, that we're doing an awful lot of things right. I know it sounds surprising, but it's true. We are doing many things quite right in our healthcare system. We are getting, for example, value for our healthcare dollars in terms of medical science and technology. Just one example, the United States leads the world in medical science. Of the 143 Nobel Prizes in physiology and medicine since 1945, the United States captured 87, outclassing every other country in the world. There's not even a dispute about that. We are the global destination of people who are very sick, who are seeking advanced medical assistance, and that's not a bad thing. We're the leaders of the world in the pharmaceutical revolution. The United States has been a leader in developing new drugs that have revolutionized the medical profession's capacity to combat disease. We've pioneered vaccines to prevent a lot of diseases. We've pioneered the first statins to lower cholesterol. Right now, we're working on new antivirals to enable AIDS sufferers to cope with HIV. Between 1996 and 2006 alone, the United States developed over 160 drugs to treat rare diseases. And we're testing over 800 drugs to cope with diseases related to aging. These are good things. In terms of medical outcomes, we've made enormous progress. According to the Centers for Disease Control, since 1999 alone, death from cardiovascular disease, heart attack and stroke, have declined by 25%. It's a stunning achievement. We're making serious progress against cancer. It's a killer. It strikes almost every family. According to the National Cancer Institute, the death rate from cancer has been declining about 1% per year since 2002. Recently, 2% a year. The survival rate, 5-year survival rate for early-stage breast cancer because of early detection and rapid treatment is now about 95%. And we've seen clear declines in disability among senior citizens over the last 20 years. Generally speaking, a senior citizen who is 65 today is a much healthier specimen than a senior citizen was in 1965 when Medicare was first enacted. So, not surprisingly, life expectancy is going up. Now, I think what I would say to the next president is, yes, you're going to hear a lot of criticism about the healthcare system. We're highly critical of our own performance, the performance of our doctors and hospitals, and that's not a bad thing. I don't want to be misunderstood. I think it's a good thing. But we have to keep our criticism in perspective. And we have to recognize that we've got a mixed bag here. We are getting very good value for our dollars in terms of medical science, research, and technology. And where Professor Reinhardt and I am certain where we would agree is we are not getting good value in terms of our financing, the way in which our third-party payment systems work, not only in the private sector but also the public sector. Let me clarify what I mean. We do not have a system today which is governed by normal economic incentives. Some people say that when it comes to health care, normal economic incentives have no role. But even where you could make an argument that normal economic incentives do have a role in many areas, such as insurance, these incentives are not operating clearly. America's households, not employers, not the government, pay 100% of health care costs. But American households contribute 100% to the cost of health care. But in terms of actually controlling the flow of dollars in the system, American households don't have very much control at all. In fact, Jason Furman over at the Urban Institute said it's about 15 cents on a dollar. Well, those who control the dollars call the shots. Ideally, I would say to the next president that ideally, families, individuals and families should control every red cent spent on health care, as they do in virtually every other sector of the economy, where people make normal economic exchanges. Now, what does that mean with regard to health care? I just want to give you a few examples of what that would mean. It would mean that individuals and families would own and control their own health insurance policies, just like they control their life insurance, auto insurance, homeowners insurance, and every other type of insurance, and be able to take that insurance from job to job without either a tax penalty or a regulatory penalty. It would mean that individuals and families would be able to get the benefits that they want. Not what somebody else says they must have, but what they want and what they need. It would mean that they would be able to compete, that doctors and hospitals and plans would compete on a level playing field. Now, those of you who are familiar with state health insurance markets know that that doesn't exist in many parts of the country. I used to be a member of the Maryland Health Care Commission. I was a regulator, believe it or not. I did it. Yeah, I really did. Uwe, honest to God. And we did a great job. We had a small group market. We ended up with 2 companies controlling 94% of the covered lives in the state. And for the small group market, 58% of small businesses didn't even participate. You know, very, very good. We know how to do this. And, of course, the fact is that health care costs in Maryland, continue to go up. I think that in a rational world, which is what I would recommend to the president, is that individuals and families who shop for health care plans would know the real price of the health plans, the price of medical services. They'd be able to compare performance and quality in an information-driven market, really. And moreover, individuals and families would be able to pick health plans and medical professionals that support or at least accommodate their ethical, their moral, and religious convictions when it comes to biomedical ethics. I think right now this is not an immediate problem for most Americans. But with a rapidly aging population, when we're going to start talking about what end-of-life care really means and what is, in fact, appropriate care at the end of life, this will start to become a more serious issue. And I just asked John Rother to keep that in mind. Anyway, that's my vision. Yeah, that's right. Otherwise, I won't renew my membership in AARP. One other thing I would say to the president, there are going to be a lot of proposals that are going to come before your desk to deal with the health care problem. This is a huge sector of the economy. You can't do it all. There are going to people who are going to be coming to you with all kinds of very elaborate schemes to improve the delivery of care. What can you do, and what can you do efficiently and effectively? What you can do effectively and efficiently is to focus on the financing of health care in the United States before you delve into the business of trying to figure out how to get the best health care delivery system, the financing. And that brings me to my fundamental message to the president and to everybody here. The one area where it seems to me that where we have a genuine consensus among liberals and conservatives, among economists, is that the health insurance markets in many respects are flawed, and they are flawed because of the existing tax treatment of health insurance, the federal tax treatment of health insurance. Now, you all know this, but I'll repeat the obvious because in my experience in Washington, the obvious is always overlooked. In the United States, if you're an American citizen, you get unlimited tax relief for the purchase of health insurance if and only if you get health insurance through the place of work. And for those of us who are at the Heritage Foundation or work for a big university or a big trade association, it's a pretty good deal. Get a large chunk of tax-free income. But if you talk about the folks on Uwe Reinhardt's blue line, right? A lot of folks who work for smaller businesses where the businesses do not offer health insurance and the employer cannot afford it for one reason or another and they have to buy health insurance on their own. What do they get if they decide to buy health insurance on their own? They get nothing. They get absolutely nothing. And if you look at the numbers on the uninsured, what you will find overwhelmingly is the overwhelming majority of these people are young people, working people, most of them are working people, who work for small businesses. And if you look at the data on the uninsured, you also know it's not people just having access to coverage, it's people being able to keep it. And that what happens with the uninsured is people are transitioning in and out of an unstable health insurance market. We've got to change that. We've got to change that. People have got to be able, we have got to have a system where health insurance sticks to the person, not just the job. That's what I would tell the president. Now, you cannot talk seriously, it seems to me, about fixing the health insurance markets unless you zero in on the key weakness of the American health care system, which is the inequitable and unfair federal tax treatment of health insurance. If people are not able to get health care through the place of work, they have to go outside and buy it on their own in the individual market, and we all know what the individual market looks like. In some states, it's actually not that bad. In other states, it's quite not functional. But when people buy health insurance on their own, with after-tax dollars, they're being forced to pay something like 40 or 50% as much as 40 to 50% for the same package of benefits they would get if they got their health insurance through the place of work. This is profoundly unfair. Today's tax system not only undermines access for millions of Americans to affordable and reasonable health coverage, it also fuels overinsurance. We buy too much subsidized coverage, and we fuel higher health care costs. So I would say to the next president, a lot is going to be presented to you, but a change in tax policy would sharply reduce those who are uninsured. You would have an opportunity to create a level playing field for different types of insurance. You would open up the opportunity for millions of Americans to get the coverage of their choice while reducing the burden on taxpayers and hospitals today who provide free care to the uninsured in the most expensive place on the planet, the hospital emergency room. Thank you very much.
Good morning, and thank you to Princeton for the opportunity. You don't have to be in health policy very long to know the first rule in health policy is never directly follow Uwe Reinhardt. So right now we're in a time of maximum uncertainty with regard to the future of health care, and I think it's very much like being in the middle of a hurricane. You simply don't know where you stand until the clouds clear and you can assess. And I think the current financial crisis will be resolved one way or the other by the time we hold an election. And by January, I think we'll have a much clearer picture of what's possible in health care. So I'm not going to make any predictions about that. But what I will say is that I believe health care is a fundamental economic issue and that we ignore it at our peril. I think the most expensive option in front of us is to do nothing. Today you saw the federal employee health plan premiums going up 8%. Over cited the figure that family coverage is $15,000, and you don't have to compound very many years of 5% increases before you realize that this is the long-term challenge, not only to the federal budget, but to family budgets and to the budgets of business. This is the big issue, economically. You know, if we only paid for health care at the pump, I think people would be screaming a lot more about health prices than they are about gas prices. You know, $15,000 a year, can you imagine? And, you know, part of the problem is that those costs are so hidden today. Most consumers only see what they pay at the point of service out of pocket. The true burden that affects their ability to pay their mortgage, that affects their ability to pay for gas, is health care. That's kept down the increase in real wages, and it's certainly a drag on the economy to the extent that we are not getting good value for the dollars spent. And I agree with Bob that today the healthcare delivery system is not providing that value. So what can we say about the presidential plans? Well, the first thing I would say is they're only directional. We don't have the kind of spelled out plan that we would need to make any kind of detailed assessment. But on the other hand, when you look back over the last, over our entire history of proposals put forward by presidents during the campaign, we've got a lot more today than we've ever had before. There's a lot more detail, a lot more sense of what the presidents would do today than any previous election. Why is that? I think it's Hillary Clinton. She put out a series of 3 very specific proposals, and everyone else had to respond. And so I think we owe her a little bit of debt there. But the larger point I want to make is that the president, the president is the person that sets an agenda to tease the issue up. The president is not the person who formulates a plan. That's the Congress. And I think we have a better idea of what the Congress is going to look like than we do of who's going to sit in the White House. And I think that, you know, we are going to have some health initiatives out of the Congress. So I think one role for the President is to make it clear to the American public why there's urgency around health reform and to encourage the Congress to get at it. Now I have 5 criteria, or necessary elements that I think we should bring to this discussion. And I think the presidential candidates have met these criteria to a greater or lesser degree, and I'll comment as we go along. But the first and the point that flows out of my introductory comments is it's imperative that we start to bend the curve of healthcare cost growth. And this is not a matter primarily of the federal budget. It's about the total healthcare cost growth. We are not getting good value. We have a lot of information about where the money goes. In Medicare, about 3/4 of it goes to people with chronic conditions, often multiple chronic conditions. We have a healthcare system that's not set up to treat those people very well, very successfully, and not surprisingly, we have lots of evidence of waste and missed opportunities to keep people out of the hospital, keep them healthier. If we only had a delivery system oriented to chronic care. We spend about 20 to 25% of our total health costs on paperwork and administrative overhead claims. No other healthcare system in the world tolerates that. And if we wanted to save some money without impacting care, that would be an obvious place to focus. So partly a function of our fragmented system, but everybody has their own definitions of what's covered, what's not. Go to any hospital, ask them to talk to the people in claims, and you'll get an earful. We're simply not serious about saving money unless we standardize claims filing and try to bring that percentage down. We do have a lot of technological progress, but we also have very little way of knowing what's helpful and more efficacious than what exists today. And we have many examples in pharmaceuticals and other procedures where the newest and most expensive isn't, it turns out, necessarily safer or better. So we need a comparative effectiveness effort. We don't have that today. All we have is this product better than a placebo? That's not good enough. And we're not going to bend the curve on healthcare unless we make physicians partners in that effort. And certainly today, under a fee-for-service reimbursement scheme, we're rewarding physicians for volume. We're not rewarding for outcomes. We're not rewarding for good patient management. We're not rewarding for the things that we really should be rewarding them for, so we need to change the way we pay physicians. So all of those are necessary elements of any serious effort to bend the curve on cost growth. Medicare can be a leader, but ultimately these things need to be system-wide. Second thing is we need to make healthcare affordable for individuals, families, and business. So bending the curve still means that costs are going to grow year to year, just hopefully not as much. How do we make coverage affordable? Well, you start by including people in pooling mechanisms, even people who are not getting their coverage through an employer. You need an out-of-pocket cap in major medical benefits so that people are not driven into bankruptcy by health care costs. And you need subsidies for low income, maybe even modest income. So these things are expensive, but they're necessary to keep coverage and keep health care affordable. Now, related to that, the third criteria is coverage really needs to be fair and adequate. So we do need guaranteed issue. You know, we're the only country in the world where if you're sick and you need coverage, you can't get it because you're medically underwritten. So certainly guaranteed issue should be a litmus test to the adequacy of any health proposal. And likewise, coverage should be portable. You should not have to stay in your current job because you're worried about losing your health coverage if you move. That's not good for the economy. It's not good for individuals. So guaranteed, portable, need adequate benefit, because as I said, out-of-pocket costs, if they're too extreme, can defeat the whole purpose of insurance and financial protection. And coverage has to ensure real access. So unlike, for example, Medicaid, where we say people are covered, but then they can't see doctors because doctors in their community don't accept Medicaid, you need to have a system that actually assures people that they can get care when they need it. Okay, so bend the curve, make coverage affordable. Coverage has to be fair, adequate, and then, of course, coverage needs to include everyone for lots of reasons, to end cost shifting, to actually promote health. But we do know that the uninsured are diverse, and we do know that a voluntary system isn't going to get us there in the fact of life. As Uwe said, in New Jersey, other states, we've tried voluntary approaches to coverage. For lots of reasons, they don't work. And then finally, we do have to pay for this. And we should have a stable and adequate source of financing for health care. And I think there are some elements on the table. I think Senator McCain ought to be congratulated for putting the tax code on the table and the tax treatment of health premiums. However, I will say $5,000, if a policy is going to cost $15,000 for your family, isn't really going to do it, especially if it's not indexed over time. I think the one example of a creative financing idea was in California, where Governor Schwarzenegger put forward a plan, and he said to the hospitals, I'm going to take care of your charity care burden. I'm going to take care of your underpayment in Medicaid by making sure that all residents of California have coverage, so I expect you to give back some of those savings. So a 4% give back from hospitals, and he proposed a 2% give back from physicians. I think that's fair. I think that's a way of spreading the costs without adding huge amounts of additional spending to a system that's already probably too expensive. But ultimately, I think you have to assess each proposal for health care on the grounds of shared responsibility. Does it spread the costs broadly? Do individuals, businesses, and government all have a role to play? And can we say over time it's going to be adequate? And certainly what we have today doesn't meet that test, and I'm not sure that either candidate has really stepped up on that one. So finally, I'll just say I think that politically, I think there's lots of agreement on cost containment elements that both Senator McCain and Senator Obama have identified. They both talk about chronic care. They both talk about health information technology. They both talk about comparative effectiveness. There's an agenda here that we need to get serious on and push right away that they share. But I do think that ultimately we have to recognize that our political system isn't very good at dealing with all this stuff. And that maybe if we're willing to have an executive branch agency to deal with Wall Street that's subject to congressional oversight, maybe we need an independent or executive branch agency to deal with health care that's also subject to congressional oversight. So something like a Federal Reserve for health that would take some of these decisions out of the political realm and drive toward a more integrated, more coherent system. And then finally, I think if we can't do it all, and I doubt that we can, in one massive bill, we've been there before. I think it was Bill Clinton who said we bit off more than we can chew. then I think a staged approach can make some sense. But stages have to be locked in. You have to commit yourself up front to saying by a certain date we're going to do this to further delivery reform, we're going to do this to further coverage expansion, and then by another date we're going to complete the job. And if you don't lock that in, then you have to start all over. And we know from the history of presidential initiatives in healthcare that unless this is a priority and unless it's launched in the first year of a president's term, it's not likely to be successful. So, yeah, we can think about stages, but it's my advice to the president, number one, it's urgent. Number two, there's a common agenda on cost containment. We need to get started. Number three, if you have to go to stages, lock those in. Don't just assume that a future Congress will come back and finish the job. And number four, don't get locked into the perfect being the enemy of the good. There's lots of ways to do this. There's lots of options out there. Needs to be bipartisan, needs to have buy-in from business community, from healthcare community, from consumers. It's got to get going. So we can't wait for the perfect. So my advice is make it happen soon and just point us in the right direction and set up a mechanism that forces us to act. Thank you.
Thanks very much to our panel for those insights and for profoundly depressing me for the rest of a rainy Washington day. We'll now open the floor to your questions. We do have a microphone, so if you could please wait for it. Just raise your hand and please ask your question in the form of a question. That's where your voice rises at the end of a sentence and makes a little question mark. So go to you first. You just please wait for the mic. And if you have a question for a specific panelist or the panel overall, just let us know.
Thank you very much. Grace Marie Turner, Galen Institute. Can I make just a quick comment before my question?
Sure.
This issue of the $5,000 tax credit that Senator McCain is offering and the $12,000 health insurance policy. It's really important to understand, first of all, that on the employer side, nothing changes. It's still deductible. Health insurance is still deductible for the employer either way. But on the employee side, the current invisible tax break is replaced with this credit. The government's job is not to replace the entire amount of your compensation that's going to health insurance. The $5,000 is replacing the tax break, which is worth an average of $4,200 to the average American family. So it's more than they're getting. Then that part of their compensation package is also put on the table that's going to health insurance. They're just not seeing it. And out-of-pocket costs also, their share of the premium go on the table. So it's easy to see how you put together the $12,000. I don't think we're having a debate about the government replacing all the money that now is part of employees' pay to provide health insurance for everybody. So that's just sort of clarifying the flow of funds. Second of all, yes, Mark.
It's my understanding, though, that the business. Did you say the businesses weren't losing their tax exclusion?
That's right. They're losing. The exclusion is on the employee side. There are two tax provisions in the Internal Revenue Code that apply that forgive health insurance from taxes, on the employer side and on the employee side. For employers, they're still going to deduct it, whether it's called health insurance or cash wages. So it doesn't change on the employer side.
But that's assuming that the employer uses that money for wages.
Well, I think it's going to be real hard in a competitive market. I mean, the reason they offer health insurance.
Sure.
Sorry.
So we don't have a revoke.
Right.
Ask your question? I'm sorry.
Maybe we can get a my question is, knowing that the Children's Health Insurance Program has to be reauthorized by March 31st, what is the one thing that each of you would recommend that the new president have as his primary agenda on health care to get the ball rolling and to really make a mark and make a difference in getting something started on health care? The one policy provision that you think could make the biggest difference?
Anyone?
I'll go first. I think the first thing that he ought to do is refocus existing spending on low-income working families with children, and that right now is 200% of poverty. For those families between 200 and 300% of poverty, between roughly $42,000 to $63,000 a year, what I would do is I would establish a refundable tax credit for the children in those families. So I would provide middle-class tax relief for them. What I would not do is expand S-chip to the point where it displaces private insurance coverage for families and children. I would not do that.
I would practice what is called paternalistic libertarianism, which is a new thing, which means any child born in the United States, of whoever the mother may be, is ipso facto insured with fairly comprehensive coverage, period. It's just like if you're born on this soil, you are a citizen, even if your mother is an illegal alien. The same thing is you would be insured. That just simply, in my view, is what being civilized vis-a-vis children means. How, if you want to buy out, you could of this and get private coverage. But if for whatever reasons parents did not want to do this, your child would be covered no matter what it is. If you had this, you could have the school as a wonderful place to watch over the health of children, over their preventive care. I once sat next to the wife of a British lord, and I said, "What do you do?" She said, "I'm a school nurse." And I said, "Well, what does a school nurse in England do?" She says, "I'm their mom." There's a lot of mothers who actually don't look properly after the children's health care because they don't know, or because they're illegal aliens, they may be scared, whatever the reason is. She says, "I check their health, and I can send them to any doctor because I know the doctor gets paid because the kid is insured. There's no question about this. This wouldn't cost a whole lot of money at all." And one could even say, although I believe people who bring children to the world and raise them already make such a huge contribution to society that society could bestow that privilege on them for free, as it is in every other nation. Because being a parent is a big job. It's a huge job. As I always say, when they read my CV, they put all this junk on there, but the biggest contribution is to have given this country, my wife and I, 3 highly educated kids. One of them was a Marine. Now, why should you not thank me for that? And why should you not have given my kids health insurance? And I would pay it with general taxes. I'm high income. I pay a pretty penny for that. I'd be happy to. As I pay the education of all the kids in Princeton who go to public school. My kids went to private school, but I paid taxes to send everyone else to public school. Did I whine? No. I'm glad they get an education. Why can we not be a nation? Every other country I lived in was a nation. We're just a place with people who happen to share a geography. What really troubles me as a military family member is that the very people who leave uninsured and the very kids we leave uninsured are the ones we look to do the fighting for us. The officer corps comes from universities, but my son says his platoon came from the barrios. So why should we not, when we look to put their body in harm's way to protect us, at least make sure these kids have health insurance? So I think I'd go at this with the president, not just with some technical parameters and elasticity. I would remind him what a nation is. I would start right there.
Anyone else want to tackle that? Or we have time for about 2 or 3 more questions, so I'm sorry to cut this off, this portion of it. But, sir, just wait for the microphone, please. And I'm sorry, please identify yourself before you ask your question.
I'm Tom Donlan with Barron's Magazine. Could you give a relatively simple explanation of why it is that we already pay per capita much for our government beneficiaries in healthcare as much or more than European and Japanese systems do, and yet we have so many people uninsured? Who is getting the extra money that the European systems are not spending? Given, especially given the fact that their outcomes are reportedly far, at least as good or better than ours.
If I can find it. First of all, when you do international comparison, OECD numbers, and plot health spending per capita in purchasing power parity dollars, and plot it on GDP per capita in purchasing power parity, you get a line, a regression line, with an R-square of 0.9 almost. That is 90% of the international variation in health spending can actually be explained by just knowing GDP per capita. Oddly enough, aging has absolutely nothing to do with it. If you tell me what percent of a nation's population is older than 65, it'll explain absolutely nothing. So it's a very interesting thing. Nor do we now know, if you look at the CBO numbers, aging is not a driver of the annual growth in health spending. There have been Paul Ginsberg, myself, Peter Orszag, we all agree on this. Aging is not a driver of anything. GDP per capita is. But if you then adjust health spending by GDP to say, given our GDP, what would we be spending if we were like all these other nations? I think that would be $1,800 per capita less than actually we spend. So that $1,800, you ask yourself, what is that? Well, part of it is we pay much higher prices for everything than Europeans do. In part because we're richer. Our doctors get on average, 5.6 times average compensation. And in Europe, it's more like 3. But one of the reasons why that happens is, I know these kids because I taught them for 30 years. They either go to Wall Street or they go to medical school. And part of their reference thinking is, I was just as smart as anyone who went to Wall Street. Why should I be driving, wearing hush puppies and drive a Toyota, and they have a house in the Hamptons? So some of it is sort of reference pricing. They demand this, or if you pay them like European physicians, a lot fewer American kids would go in. Now, how do I know this? Well, I know we have a shortage of primary care physicians. Everyone says that. And in our genius, we say to solve this problem, we'll pay them much less than radiologists, of whom we have too many, right? I mean, that's how we solve this. I enjoy America. It's like being in a zoo without having to pay an entry fee. Because this is Meshuggah, this is nuts, in fact. But there you see the effect of compensation on physicians, right? So I'm a defender of physician income and said, hey, we are a richer nation, and our physicians, who are really great people, should be well compensated because people in their intellectual and industrial, in terms of industry, hardworking class, lawyers or bankers, they make so much more than they do. We should be thankful they work, the docs, for the money they do get. So we pay a little more. We also pay more for drugs. It's well known. We subsidize R&D better than other nations who mooch of us, you know. And there was once a Canadian at the Institute of Medicine who says, hey, yes, we're mooching. Why shouldn't we be stupid if we didn't? Right? We're small, you're big, you're doing it, so we're mooching. So it's nothing to do with fairness. It's market. They use that power. But then we have, I think, administration. I don't know what the estimates be, maybe 150 billion, 200 more on administration than any other nation would for what they are getting. And that's because of this unwieldy, Bob says, this crazy health insurance system, particularly for small businesses and individuals. The administrative overload on the premium can go up to 30%. It's quite high, so we need to get that down, maybe through a connector. But there is a paper we had in Health Affairs, Jerry Anderson and a bunch of us. One was called It's the Price is Stupid, and 1 year earlier, in May of 2004, we went systematically, why are we spending more? So it's really not that big a deal. The major reason is we're spending more because we're a well-to-do nation, or were. Hopefully it will remain, but we'll see.
As moderator, I'm just sort of hanging on to Uwe's call desperately, just sort of letting him go on forward like a freight train. So does anyone else want to address the question? Or did you want to answer his question? Or ma'am in the back? Oh, I'm sorry. Could you just wait for the mic for a second? I'm sorry.
It's
right there in front of you.
Professor, on this cost issue, have you been able to separate the cost of the, so to say, litigious society on medical decisions, on tests, etc., 100 MRIs, that kind of thing? Can that be separated, or is not significant in your view?
I think there are various studies. When you look at the cost of malpractice premiums as a function of the whole, it's about 1%. It's very small.
Anyone else?
We've got a couple more questions.
One more question, sir. And please identify yourself.
First, a correction. My name is Tom Berger. I'm with Vietnam Veterans of America. Correction on the socialized medicine comment about the VA. Less than a quarter of America's veterans use the VA. And secondly, there are income limits. People who earn over $25,000 a year do not have access to VA benefits, pensions, and the like. Nevertheless, my question is, what will the role of the war-injured health have on the larger impact of the health care if we take a look at Bilm's and Steiglitz's papers relative to the cost of health care to our troops?
Well, we know the number, right? No. Or, I mean, there have been estimates. There's a book by Joseph Stiglitz and Bilmer who put this as fairly high, and that has to do with the nature of the injuries that this war produces. It's actually a great thing in some way that soldiers who would without question have died now make it because the military health service is so excellent at the front lines. So you have these, and also the nature of the war. I mean, either you just roll your Humvee and nothing happens, or they blow it up and you're terribly injured. It's sort of, they're no longer these just firefights. Most of the injuries don't come from firefights. They come from these horrible explosions. And I think the money is big. I mean, these estimates, they are Topol and Murphy from Chicago question these, and there are some debates. But there's no question that the cost of the war is much higher than the annual budget we now spend, because you have to think of the pension and the mortgage you write. There's no doubt. I mean, I personally am a great fan of the VA. I used to serve on the SMAG, on the advisor. I just say I think it's ironic. It's actually also thought to be a fairly good health system in terms of IT and quality. Our son uses it. He's very happy with it. And I just pointed out to say that we have everything in America anyhow. And I think the VA, I'm grateful we have it. And if others can buy out, I think people should have that choice. But it just shows you socialized medicine doesn't have to be bad. And I don't think the VA is bad.
We'll give one more question, since if there is one. Sir, right behind the camera, please, Rebecca.
Hi, I'm Barry Passett, healthcare consultant, and I'm wondering if before you quit, you'd say something about the fact that the 16% of GNP, which looks like a big burden, is also an incredible source of opportunity. That's money in the GDP, and it's carved up into a number of big pieces, doctors and hospitals and insurance companies and the like, all of whom have tremendous vested interests in keeping it just the way it is. There's far more, I would posit that there's far more breaks there, not breakage, but the brakes on any kind of change than in many of the other things that we've discussed. So the issue that every time an idea surfaces, at least 1/2 of the major healthcare lobbies blows it up, makes it hard to see how we're going to do an incremental improvement in what is, for people within the 16%, the best system in the world.
So want to tackle that? Bob?
Well,
John?
I think that's the rationale for doing bigger packages rather than smaller, because you have to appeal on a shared sacrifice basis to the providers, to everyone involved. No one wants to be singled out. And if you do things one step at a time, it's much more difficult than if you can try to do things that involve a lot of people, so there's more give and take across the board. But that's a political art, not a science.
I'd agree. You're talking about a huge sector and a very complex sector of the American economy. And you're absolutely correct when you say that there are large numbers of very, very powerful people who have a vested interest in keeping things exactly the way they are. It is also the most highly regulated sector of the American economy, actually, in the sense that it attracts, it results in the fact that you have basically an army of lawyers and lobbyists and consultants who are paid very, very good salaries. The main reason for that payment is to make sure that their particular clients are going to continue to get the best possible deal. We had a classic example of that this summer. Under the Medicare Modernization Act of 2003, the Congress of the United States said, look, we have got to have a more rational pricing for durable equipment and medical supplies in Medicare. And the Congress in 2003, Democrats and Republicans alike, agreed that what we should have is we should have competitive bidding. Well, that meant that companies would actually have to come up with something that was appropriate on a competitive basis. And there were something like 325 winners. And what you saw was an absolutely stunning triumph of special interest politics on Capitol Hill. Republicans and Democrats alike, Pete Stark leading the charge against competitive bidding, making sure things stay exactly the way they are, supported by Republicans in the House of Representatives. So there you are. That's just one example. It happens every day of the week. In fact, it happens before breakfast. So now, this is a hard thing to do. I can tell you that when I was on the Maryland Health Care Commission, I wanted to see more competition in the Maryland health insurance markets, and I can tell you that the insurance companies were not interested in that at all. So, you're right.
On that hopeful note.
Yeah, I would first of all say what you need is a very, very strong leader. And Kirk yesterday gave a talk and he said, you know, I know a Princeton fellow who knows how to deal with insurgents, because the lobbyists are really insurgents to me. And General David Petraeus, we trained him at the Woodrow Wilson School. I had many a lunch with him. And I thought, what if we made David the HHA secretary and say, you deal with that insurgency? The surge worked, in my view. So maybe if David would be kind enough to do it for us, we'll ask him. I'm going to write to him just as an idea, you know, he could. But the other interesting thing about healthcare, which is often overlooked, if you look at the annual increases in gross domestic product in the U.S. 2000-2004, the number up on top, say, take the year 2002, GDP grew by $360 billion, of which healthcare was 182. Or if you do this in percentage, these are the percentages of year-to-year growth in GDP in that recession period that was contributed by GDP. Business investment actually drew the economy down, and the great housing boom is those little blue numbers. It was good, it helped, but nothing like healthcare. And there was this thing in Business Week, what's really propping up, healthcare added 1.7 million jobs, the rest of the private sector, nada. That's Michael Mandel, PhD, used to teach at Harvard. And he has a blog. If you blog it, he keeps this up. But over the whole business cycle, healthcare contributed half the new jobs. Half. So one of the problems, and you see that when you have a commission like in New Jersey, you say, hey, this hospital really don't need it. We should close it from a medical point of view. We don't need it. And then they come and say, but it's the biggest employer in this town. And I think that also makes cost containment. Another word for cost containment is income containment. Very, very difficult. So if you ever do have cost containment, you got to have 10-year horizons and say, we're not going to cut anyone. Simply, instead of letting it go up 10%, we're going to try for 7%. I mean, that's the most you can get in the short. And people should keep that in mind. This is now the economic locomotive of the American economy. When you tinker with that, if there were no health spending growth, I don't think President Bush would have been reelected in 2004. So it's an interesting sideline. I think you hinted at that. It's a big sector, and that's why a lot of incomes depend on it, and they'll fight. But what do you think of this Petraeus idea? You know him.
He would be more than up for the challenge, I'm sure. He's got another job to worry about, though, I think.
Can you see Washington full of Humvees with M60 machine guns? Any lobbyist, wham.
That's what we call a bold initiative at the Wilson School. So, but on behalf of the Woodrow Wilson School at Princeton, thanks so much for joining us this morning. This was a great discussion. Thank you to our panelists. And we'll see you soon. Thanks so much.